Hi, everyone. Welcome to the RheumNow daily recap from ACR Convergence 2024. We're all here in Washington, D.C., and we're going to, this evening on this recap, sort of give you our views of what was the most notable of abstracts today. I'm joined by the RheumNow faculty who are here. I'm going to ask everyone to introduce themselves, and then we'll get into what the highlights of the day one here in Washington, D.C. was. I'm Jack Cush from Dallas, Texas. I'm joined by Mike.
Hi, everybody. Thanks so much for having me.
That's Mike Putman
From
in
Medical College,
Wisconsin.
Wisconsin. Sorry,
There
Mike
you
from Medical
go.
College, Wisconsin. Thanks for having me, Jack.
Adela.
Hi, I'm Adela Castro from University of Tennessee, Memphis. Thank you for having me.
And Sheila.
Hi, I'm Sheila Reyes from the Philippines, and it's my first time joining RheumNow face to face.
Yeah. So I love this group. I know all of you, and what you need to know about this group is they were all over the place today, and they had fun. And learning should be fun, and if you do it right at ACR, it's really the only way to go. So why don't we begin with Sheila, and then we'll do Adela, and then Michael. Sheila, go ahead. What's
Okay,
your first?
so my first would be the abstract 819. So it's from the group of Dr. Dennis Padubny, where they gave the ASAS definition of difficult to manage axial spondyloarthritis. And so I was able to also interview Dr. Padami earlier, and this criteria took a while. It took them around 3 years to come up with a consensus definition because there were a lot of stakeholders. So basically, they came up with a criteria for difficult to manage AxSpA that included like three main elements. The first of which included um, failure of treatment failure of at least two DMARDs with different mechanisms of action. And then another included signs and symptoms showing inadequate response or like high disease activity in terms of high CRP. There are persistent symptoms of inflammatory back pain and other symptoms that are connected with axSpA. And also there was a third element, which was also interesting because they also included signs and symptoms which the physician or the patient think is still problematic, that is making the axSpA worse. And also within that subgroup of the difficult to manage axSpA definition, they also came out with refractory axSpA, where they defined it as failure of two biologic DMARDs and then an ASDAS activity score of more than 2.1 plus either a positive CRP or a positive MRI finding, and other causes or other signs and symptoms that did not really or was it not really included in the difficult to manage ACT-SPA. So I think there's still future directions and that we would eventually know if these will be included in the new guidelines and how it would fare with um, how to manage patients with axSpA, including who will be using or like which group will be using this definition of difficult to manage axSpA.
So, Adele, and I'm sorry, Sheila, let me get this right, that the refractory definition is different than D2T, difficult to treat. And it sounds like it's supposed to be even more evidence of activity. Is that right?
Yes, it sounds like that. So it's a subcomponent of the difficult to manage axSpA in that so it's a smaller population of patients that are difficult to manage, so they become refractory to treatment.
So let me ask our other panelists, what do you think of this? Is this an advance or is this just nomenclature and nosology that means nothing to the practitioner? Adela, what do you think?
I think it's more like nomenclature, but I also think it's important to kind of like have that kind of like that consensus definition. So we know, like, particularly which patient population we should be targeting more, like, hey, this patient's going to get more difficult to treat, because the reality is that there's still unmet needs for treatments, particularly patients with AxSpA. And we know that the difficult to treat patients are the ones that have other comorbidities like uveitis, like they have like inflammatory bowel disease, they have other conditions going on. So there's definitely a need, for treatment of these patients. So identifying these risk factors and identifying and having a consensus on the definition in particular, like which patients are kind of like these difficult to treat patients, then we can approach a more like multidisciplinary, and we have to, kind of like discuss with the patients and kind of like get this risk on earlier before when we start, seeing the patients.
I'll
Mike,
bring
what do
them
you think?
together. I'll say that it's nomenclature, but that it also may be useful. I think that often with our diseases, we try to think of them as a monolith, some sort of homogeneous entity called AxSpA, but more likely there's multiple underlying immunophenotypes that are driving these outcomes that are so different from each other. And so anytime you can find a meaningful way to separate subgroups of patients within a rheumatic disease, I think that winds up being progress, because you can understand better and then study better these populations that are more refractory. Caveat is you always need to separate non-autoimmune things out. And it's hard in diseases like AxSpA because there's a lot of there's a lot of musculoskeletal disorders that wind up mimicking, or if not mimicking, at least exacerbating some of the things that drive positive outcomes in these diseases. So nomenclature that could be useful as long as you're careful would be my take home.
Yeah, and I think
You know,
it's also important because inflammation may not be the only driver that's causing problems. So there can be like psychological factors or depression, fatigue, musculoskeletal.
but this is where it gets muddy, right? I mean, this is all been done by RA. We have a EULAR
Yeah.
definition for RA, and that one was applied to populations, generally shows, 10, 12% of all RA patients are D2T RAs. But then now you get into how many of those are inflammatory or non-inflammatory pain, because pain is the largest driver of these D2T populations. What I like about what Dennis was doing is that he's trying to put in activity requirements that are more objective, maybe more inflammatory, and get you towards, because if you have a definition of D2T AxSpA, maybe with that definition now you can study interventions. The problem is if the intervention is functional, a biologic's going to do you no good and whatnot. So I think they need to work it. I was almost liking that the sound of these, that it might be trying to avoid the fibromyalgia, depression, anxiety, my dog ran away kind of personality things that can factor into this. Failing drugs, because there's a lot of reasons why people fail drugs. So that might be the entry in, but trying to homogenize that population with these definitions might be a step ahead of what they're doing in PSA and in RA, my opinion.
Yeah, no,
Okay.
on evaluation on the research studies, they were more strict that you have to meet these 3 criteria, which were like, one of them was very objective, which was, the elevation of the CRP, and then the HLB27, as well as and then like kind of like the failure of at least 2 biologic or targeted, with, kind of like with different mechanism of action. So I think that was kind of like a little bit more stringent as far as like, a little bit less broad.
Right. Okay. Let's get on to our next one. Dr. Castro, what do you got?
So I found it very interesting. There's abstract 505 about cycling to TNF inhibitors versus switching to IL-17A after a first TNF discontinuation among patients with psoriatic arthritis and AxSpA patients. And this was very interesting because, guidelines sometimes say, the guidelines actually say, hey, you can use either TNF or IL-17, but it doesn't say what to actually do after stopping the TNF in particular. So could you continue? Should you switch? switch. So what I like about this abstract in particular, they evaluated the effectiveness of kind of like cycling on a second TNF versus switching to IL-17 inhibitor in patients with psoriatic arthritis and axSpA from the Correvitas registry. And the primary outcome for psoriatic arthritis was the change from baseline on CDAPSA, and the primary outcome for axSpA patient was the change from baseline on BASDAI. Interestingly, so in general, the cohort was mostly TNF users compared to the IL-17 inhibitors. But interestingly, there was no difference between cycling the TNF or switching to IL-17 in terms of the primary outcomes, which was, the change from baseline in this metrics. But it was interesting that particularly for psoriatic arthritis patients, there was some significant evidence in the physician global assessment of arthritis and psoriasis in switching to IL-17 inhibitors as opposed to, continuation or cycling the TNFs. As far as the axSpA, there was like no major kind of like difference, but it did make a difference on IL-17 inhibitors switching in terms of fatigue, which I thought it was kind of like interesting. So, because in general in clinical practice, depending on these patients, it seems that, definitely the TNF inhibitors are the widely used, for psoriatic arthritis patients and axSpA patients. But then it is important to consider, should this patient most likely will benefit from switching mechanism of action, predominantly in psoriatic arthritis patients. I would think about, more like the domain involvements, particularly the ones that are having disease activity, like arthritis or psoriasis involvement, as opposed to the axSpA patients. So I think this was a very interesting kind of like still creating some controversy. Something that I found a little that it missed in this abstract was the reason of TNF discontinuation. So was it because of a primary failure, or was like, the patient couldn't continue because of like a side effect or something like that? So that definitely changes things a little bit.
So were these people who only failed one TNF, or could they have failed multiple TNFs to get in the study?
One.
Okay. So maybe that makes why the second TNF didn't do so badly. The more further you go down the line, you lose that efficacy. Mike, Sheila, what do you think of this data?
Well,
Yeah,
I think, yeah.
After you.
Okay. Well, I think what it means for me as a clinician, and in a resource limited setting would be, well, at least you get options. Although, as Adela said, there was really no statistically significant difference from cycling to switching among the psoriatic arthritis patients in ACPA, but it gives you confidence, or it reassures you that whether you give another TNF or you switch to an IL-17 inhibitor, then the chance of the patient improving will still be there.
Okay. Mike, what do you think?
Yeah, I have a couple thoughts. I mean, I am generally a fan of switching for people who are primary non-responders. And I mean, the thing about IL-17s is that they're marginally more user-friendly, and I think that they do a better job on skin. And so my general clinical preference has been to shift towards cycling. This was a small-ish study. It was large enough that if there was a big difference, you think you would have found it. There was a little trend toward there being a small benefit towards switching. And so I don't think it changed my priors too much, other than saying that I'd be more comfortable trying another TNF. Going back to what I was saying about immunophenotypes, I mean, I think the people who don't respond to the first TNF up front are less likely to respond to the second one. Later on, late failures, I mean, especially if that's due to the emergence of anti-drug antibodies, then yeah, I mean, you probably still have some juice in the squeeze for TNFs at that point. But my general preference is to switch people who don't respond well to a specific class up front.
Yeah, I think that makes some sort of sense. I think we're all aware of the fact that a primary non-responder needs to change to another class of drugs. But in these situations where you don't know it, or they are a secondary or even a side effect issue, it seems reasonable to try to cycle within the class as opposed to switching to another MOA class. So this seems reasonable. And, whether it becomes a guideline or whatnot, these studies have to be done really well to show up in guidelines. And they're not always done well. That's the problem. A lot of these are retrospective observational cohorts and whatnot, and that sometimes limits their interpretability or extrapolatability, I guess, if you will, especially when it comes to making guideline rules. So, all right, Dr. Putman, what do you have?
Yeah, so these recaps, I just want to give you the hardest hitting abstract that I saw or experienced during the day, the thing I'm going to bring home from the meeting. And that was definitely abstract 0770, which was the plenary session that started at 3rd of the morning today, that investigated the use of upadacitinib, a Janus kinase inhibitor, for patients with giant cell arteritis. The study is called Select GCA. And this is certainly a study that I'm going to remember. Full disclosure, I was a participant in this trial. We didn't enroll any patients, but I have been interested in this for some time. I think we're all well aware for the past 5 or 6 years now, we've been using tocilizumab and interleukin-6 inhibition in giant cell arteritis. But if you look at the GIACTA trial, there's a large number of people who did not respond. We still see people flaring through it. We have not yet found the perfect cocktail for patients with rheumatoid or with giant cell arteritis. And so I think we've all been excited about a lot of the activity in this space. There's IL-17s, there's JAKs, there's a number of different agents being investigated. And so this was a big deal to get to see this presented. It was a big study that was conducted with no preliminary data. There hadn't been a big case series or anything. They just went straight to a phase 3, which is my bias and my preference is to, if you have an agent that you already have a rough sense for the safety profile, let's just test them and test them properly. Move things forward. There was a big 428 people were enrolled, double-blind, randomized, placebo-controlled trial. There are 3 groups. The one group got 15 milligrams of upadacitinib. There's a 7.5 milligram group that didn't do very well. It wound up being on par with placebo and a longer taper. And then there's a placebo group. And the thing is, they gave you the investigational agents. You got upadacitinib in a 26-week steroid taper, or you got placebo in a 52-week steroid taper. So even if this had been equivalent, that would have been considered, maybe a little bit successful. But what they saw was that patients who got upadacitinib, 46% of them were in remission at week 52 compared to 29%. So more likely to be in sustained remission. Looking at people who had complete remission, 37% in the upadacitinib versus 16% in the placebo group. So pretty good differences favoring the new drug or upadacitinib that were statistically significant. And that's in the context of these people doing a steroid taper that was half as long. There's a bunch of subgroup things that they tested. It looked good for FACIT fatigue and all of the smaller things that they looked into. Safety is a big question with JAKs. This is the ongoing debate since the oral surveillance trial. I think that in general, we should look at this as a class effect, with the caveat that thus far we haven't seen any clear safety signals for this particular Janus kinase inhibitor. But I'll tell you that when talking to patients about this, I still mention it as a problem with the JAKs writ large. And it's hard to sell people who are over 50 on a drug that might cause cardiovascular disease and cancer. They don't like those. But all that said, I think that this trial was definitely successful, will be approved. And I think this will be an option for patients with giant cell arteritis going forward.
So the question is, will the attractiveness of an oral JAK in these patients be enough of an attraction to overshadow the small safety concerns of JAKs in elderly people who may be at risk? And that's I'll just tell you guys what happened at EULAR. At EULAR, I chaired a session where David Liu and Janet Pope, 2 of our faculty, did a debate. And the debate was, should rheumatologists be worrying about oral surveillance data? And the interesting thing about those 2 people is that they both said that they could have argued either side of the argument because the data is so versatile in that way. But in the end, it's clear as to who may be at highest risk from oral surveillance: elderly, cardiovascular history, smoking. Those are the ones you worry about. And that could be this GCA population. Otherwise, it doesn't make sense to worry about JAK use in 23-year-olds with alopecia areata or, something else you might be treating. In the end, when we asked the audience, How many of you are still using JAKs in spite of this warning? The vast majority of the audience raised their hand. We asked the converse, and only a minority said that they were significantly altered their JAK use. I think most people put the caveat into play. So, Mike, with that information in mind, how do you think rheumatologists are going to respond to this?
Yeah, it's funny. I mean, I think that you're kind of striking the balance correctly there, where, I think that there are some rheumatologists who will just be uncomfortable with this. And I understand where they're coming from. I think the safety risk is real. I think it's small though. And I think for many patients, it does make sense to use one of these agents. So if it gets approved, which I expect it will be, it's certainly something that I'll be offering. It's hard to know whether this goes ahead or behind tocilizumab. It's kind of interesting if you look at the different curves. It looked pretty similar to the tocilizumab data as far as efficacy. And then if you consider a small risk and maybe it's more user friendly because there's no injecting that you have to do, diverticulitis, but maybe that's just it's a shared safety issue. It gets really complicated. And at the end of the day, I think you just need to explain it to patients, make sure they understand that these are small risks, but real risks. And I think that a lot of it will come down to patient preference for me.
I agree with you. Like, in particular, when I was there in that session, and what the first thing that crossed in my mind was like, of course they had to do the placebo one, but we do have an approved agent for GCA. So I was like, why they didn't just do like, comparing it to tocilizumab, because it leaves us as to like, where do we put it in, or should we do it for like, tocilizumab non-responders, or should we go ahead and just hey, you have an oral medication that might help with this? So it's of course, very nice to have more options, for especially, to discuss with these patients. But I also was like, oh no, I'm not sure where exactly am I going to put it in my, in my order of starting these patients.
Yeah, I think that's the big question. Sheila, how do you feel about this data? Will it change what you do if it were to become available in the Philippines?
Yeah, well, I think it might. For me, what's important is as long as there's a drug that can really avoid giving too much steroids on these patients, because you know it all boils down also to just like what Mike said, patient preference. And also I think it's important that they know what they're getting into, and the monitoring, that they should be monitored. And we'll see in the future what this will bring, and hopefully it comes to the Philippines, and then maybe I'll give more data. I'll give more feedback.
All right, that's very fair, because these questions often take years to figure out, and we learn by our experience. I want to give you an abstract, and I'll do kind of quickly. I was going to do the taper study, but I watched Mike Putman do a video on the taper study today. It's a steroid withdrawal study in GPA. He did a fabulous video. You should look at that on RheumNow, or maybe Mike, you can do that as your short next one. So taper study and steroids and GPA, and whether you should wean or not. That's kind of. I'm going to talk about the fate of seronegative RA, a poster 0458 from the Mayo Clinic today. It's on their 20-year experience in 176 seronegative, meaning ACPA and RF negative RA patients, followed for over 15 years. And the interesting thing, the bottom line is in this study, and you can't beat Mayo Clinic data. You can argue with it, but I used to say all the time, I really hate Jim Odell and Ted Pincus, because I have really strong opinions, but they have really strong data, and I just, as much as I might yell, their data trumps your sound opinion or loud opinion, either which way. And Mayo's always got good data. And what they came up with is a 15% conversion rate in following people, at least for the 10-year cumulative incidence was 15%. The majority of those, by the way, were spondyloarthropathy. So it was like 30 something people changed diagnosis. About a third of them changed to either PSA or AS. 6 of them, so that's about 20%, turned seropositive RA. And now we go 5 with OA, 3 with crystal, 3 with the non-diagnosis of CTD, 1 infection, 1 paraneoplastic, 1 RS3PE, and 1 sarcoid. So that's been seen in other studies, but I always quote, like, I think it's 453, 435 patients, a Finnish study by Tulikki Soka, followed 10 years. They had a 65% conversion rate on seronegatives. So there's quite a bit of variability. But I always use this as one to remind the audience that seronegative is not seronegative until you keep asking yourself the question, is this still seronegative? You know, and you remain inquisitive at least for a few years. And it really is your opportunity to ask that question and to consider it. And then, you know, what they did find was, of their patients, I want to say 27% went into drug-free remission. So 80 of the 85% that had seronegative RA didn't become something else. 27% went into drug-free remission, and 19% had refractory disease enough to require either a biologic or a JAK inhibitor. So that seems reasonable. The data on seronegative is that to be seronegative, you almost have to have pretty severe disease. It's not easy. Not all seronegative is aches and pains and something that you think meets criteria, but a lot of them actually have severe disease and erosive disease, and meaning they have to make up for not having the serology to actually have the diagnosis. So I do think it's instructive, and if only to remind us how we should be considering these patients. Anyone have a different view of this?
I wonder if, like, you know, the ones that went into remission, I'm thinking when when they go into remission, it makes me wonder more about an alternative diagnosis, you know, because we know that remission definitely needs medication in rheumatoid arthritis, and we know when patients that are in their treatment and then we try to taper or stop the medication during remission, they have chances of flaring again. So when they have sustained remission drug-free, I'm still thinking, and seronegative, I'm thinking, is this an alternative disease? So that's what I always think about in these type of patients.
Yeah, I would echo that. I have 2 thoughts on seronegative RA. The first is I always tell my fellows, well, we're going to treat this just like seropositive rheumatoid arthritis for now. And that for now is really important. And then the second thought is that the OR really matters in seronegative RA. So if you have a patient you think is seronegative rheumatoid arthritis or polymyalgia rheumatica, I'm actually going to reach for an IL-6 agent for that patient. I had a patient recently who I thought was seronegative RA or dual onset Still's disease, and we tried an IL-6. She actually benefited. We put her on IL-1. She did great. And so I think that seronegative RA, you should always ask yourself, you know, given this patient's demographics, given their constellation of findings, that funky rash they had pericarditis, figure out what the OR would be. And then we have a lot of options in RA. You can kind of bend your OR towards or your treatment toward what their OR would be.
Yeah, I mean, I agree with you because I get to see a lot of seronegative RA, and I think what's important is giving it time. Over time, sometimes there are new symptoms that will come up, there are new signs. So if you think that your initial treatment is not working, then yeah, consider the OR in that seronegative RA patient.
I like that. It's definitely a good policy to have. All right, so we're going to do one more go round with our 3 faculty and get shorter presentations to sort of wrap this up. Sheila, what's your next one?
Okay, so my quick hit is from the year in review earlier. It's the research by Cipolletta et al. I hope I pronounced it correctly, about gout flares that are followed by an acute CV risk. So they found that within the 30 to 120 days following acute gout flares, patients were at risk of developing cardiovascular problems. And so I think what the message sent to us rheumatologists is that all patients with gout, regardless of the duration, especially at the first onset or first diagnosis, screen for CV risk and manage.
Yeah, really important. Did anybody else go to the year in review?
Yes, I was there as well. I think
Do you have a favorite from there?
Yes, my favorite over there was definitely the CAR T cells. Because of course, we can see that in different, like initially they were kind of like very small, just cases, but now we're getting more and more cases of patients severe autoimmune diseases that are responding to CAR T cells. Interestingly, it works, but it's extremely expensive, like $1 million per patient. So I was like, oh my God, is the cost, worth the benefit? But at the same time, I was thinking, patients with these severe autoimmune diseases, seeing them, treating them, actually, they're very costly as well. Also, in the terms of disability as well. So I was like, maybe down the line, maybe the cost will be worth it. And something that also caught my attention there was like they presented another one on the CAR T cells about the allogenic the allogenic CAR T cells that they can actually be preserved for like a year. So that was pretty interesting too.
Yeah, the other thing that Mike Pillinger did in his 10 abstracts, he had 3 of them on knee-OA, a treatment we really don't have much for, all making big splashes in New England Journal. Krill oil in knee-OA, methotrexate in knee-OA, and what's the other one?
The maglutide. The
Semaglutide.
Yeah, yeah, weight loss drug, the GLP-1 in knee-OA. So anyway, all right. What's your quick hit, Adela?
My quick hit is hang in there. I have the number here of the abstract. It is abstract 599, and it was about sex-related differences in efficacy of biologics in AxSpA patients. And this was a systematic review and meta-analysis. Over 11 studies were included. Over 11,000 patients with AxSpA were included here, and they evaluated responses for BASDAI-50, ASDAS low disease activity response, and ASAS-40. Interestingly, most of the patients included in this trial were male, and they were most of the male patients also were HLA-27 positive. And what was interesting about this abstract was that male were more likely to achieve BASDAI-50 and ASDAS low disease activity compared to female patients, while ASAS-40 was kind of like gender neutral. So of course, it made me wonder, are female patients having more complicated disease? Is the delayed diagnosis, more in female patients that leads us to difficulty in achieving these responses, or should we just pick like a gender neutral measurement like ASAS-40 to evaluate these patients?
Yeah, kind of a hot area. Gender differences in drug responses, and it's one thing to say to heighten the awareness of this. It's another thing to have an approach to it, and I'm not sure what the approach is, to be honest with you. So, Mike, what's your quick hit?
Quick hit, another hot area with I'm not sure what to do about this. So there's a debate right now in the vasculitis world about what to do with imaging, how much to image, when to image, and when we find abnormal things, where do you go? So abstract 0742 was the use of PET scanning to monitor activity among patients with GCA who were on tocilizumab. What an interesting idea. They followed 36 patients at the NIH. They have a big cohort there, and they followed them to see what would happen with the PET scanning. And what did they find? Half of patients had persistent activity, and not like little ditzels. Some of these were pretty active patients. They have some beautiful pictures in their poster that are the kind of thing that you would treat. And so this is a real conflict that I have where I say, if I see inflammation, I want to try to treat that. But what did they see? And this is from their poster. They said ongoing FDG PET activity was not associated with longitudinal outcomes, including angiographic progression of disease or relapse risk. And this is where I just get so nervous. We have all these amazing ways to find inflammation, diagnose inflammation that we didn't have before. And all of a sudden we're treating things that we may not have treated before. And if there's inflammation that you can only find on a PET scan, but it isn't causing long-term complications, does that patient really need another 6 to 12 months of 60 of prednisone or another DMARD? Or should you be stopping tocilizumab to put them into remission because you saw some inflammation on the PET? And so this opens up this Pandora's box of questions, but these are questions that I really think we have to be answering. If we're going to be searching for inflammation in GCA and PMR, we really need to define whether or not that is going to benefit our patients. And so I thought this was a great abstract. They ultimately concluded, they said routine or serial monitoring not advisable in GCA, which is a tough pill to swallow for a lot of us who think that we need to have something to track. But I'm hoping in the next coming years we'll figure this out more. But it's a tough spot right now, and people have very strong views about it.
So these people that had the scans, were they like theoretically in clinical remission on tocilizumab?
5 had active clinical symptoms, but 31 were in clinical remission. So they were in remission, but half of them had inflammation. And so that's challenging, right? As a rheumatologist, I treat the patient, I treat the symptoms. And for people who aren't having symptoms and are doing well and aren't progressing, oh boy, it's tough.
So Mike, you're a vasculitis guy. Can you help me in the audience? I think of FDG PET as the great test for extent of inflammation, but not damage, and that other CTA or MRA are better at damage. Is that true? And then how do you reconcile that with this data?
Yeah, there's certainly some truth to that in the sense that, if I want to really characterize a stenotic lesion, then I want some angiography. If I really want to characterize activity, low-lying inflammation, I do prefer PET, although truthfully, you can get a lot out of a good CT angiogram. So, for differentiating damage, I usually, if I think someone has damage in an area, I will track it with something else. If I'm just trying to answer the question, is there inflammation here? Or I hope there's no inflammation here, then I do reach for PET. In this case, it's interesting, had we been imaging these people with something that was maybe less sensitive to activity, and so say we were doing MR angiograms instead, I wonder, maybe fewer of these people would have lit up, fewer of them would have been categorized as active, and maybe that would have been a better balance between finding disease that matters or finding disease that doesn't. But it's tough. It's a small cohort. You don't have infinite follow-up here, and so it's tough. I don't want to over-conclude it, but I'll say that it did confirm my underlying biases in this area.
It is tough because sometimes, it would be ideal to have like a baseline, a diagnosis, baseline imaging, and then, monitor that in, down the line. Okay, are they responding? So is this inflammation less that compared to baseline versus like it's just inflammation that is new? Then that will make me, think about an alternative treatment or something else. But if it's actually improving, then I'll be like, and the patient is clinically improving, then I'll be like, maybe our medication is actually working.
Mm-hmm.
The problem is this finding has been shown before in the vasculitis world. Patients doing well, but they still have, evidence of ongoing disease. And the question is, what do you do about it? In the case of RA, think about it there. You do have patients who have ongoing synovitis, even though the patient's in remission. And there doesn't seem to be good evidence that going for the imaging outcome or the finer outcome, gives you a measure of better protection. But it really does make you worry, and you're the guy that ordered or the gal that ordered the test that you have to ignore. Oh my goodness. All right. Well, let's wrap up there. This was really fun, and I'm glad you guys took the time to share with the audience your best stuff from today. We're going to do this every day, day 2, day 3, day 4 of ACR. Enjoy the rest of the meeting, guys. We'll talk soon. Bye.
Thanks,
Bye.